Thank you. Thank you very much, ladies and gentlemen. It's a pleasure to be here. I arrived yesterday with the typical weather in Vancouver of overcast and rain. But fortunately for you, I dragged along some sunshine and clear sky from Toronto, which I left, and 6 or 8 degrees. And today you're reaping the rewards of some nice weather. In the next 45 or so minutes, I'd like to share with you some of my thoughts about allergies and anaphylaxis in the perioperative period. I had very little experience treating anaphylaxis in the operating room up to the problems of latex anaphylaxis about 20 years ago. And at SickKids, we had about 35 cases of unexpected anaphylaxis over a short period of about 18 months. And needless to say, just about everybody in the department became an expert in managing acute anaphylaxis. And if you haven't had a case, it's quite unnerving when you suddenly find you can't ventilate or oxygenate your patient, especially a young child without a cuff tube, and it becomes a departmental concern for everyone. So since that time, I've spent a fair bit of time developing an interest in allergies and anaphylaxis, trying to understand a little better our relationship with those disorders as they appear in the perioperative and operating room period. And I'd like to share some of those insights with you this evening. So we're going to cover a number of subjects throughout the evening, and with a special focus on the perioperative period. Some of the examples that we're going to use will be from children, but this is not at all restricted as a pediatric talk in any way, shape, or form. So we all know that anaphylaxis is a rather serious allergic reaction that may be associated with a fatal outcome in a small percentage. The word ana means back, and phylaxis means protection from, and so we're reversing from our normal protective position, and these patients suffer from very serious consequences as a result. The causes of anaphylaxis in general, not restricted here to the operating room, you can see are varied, and I've grouped them here from a textbook on the mechanism of the anaphylactic symptoms and signs: IgE-mediated, complement-mediated, mast cell-activated, arachidonic acid mediators, and idiopathic. Interestingly enough, the associated causes of anaphylaxis the causes of anaphylaxis reported in this chapter, the 4 most common causes were foods, drugs, and antibiotics, each about 30%, latex, and Hymenoptera, or bee stings and wasps. And this is over the general population in the community. And here we see, of course, some of the classic examples where peanuts focused in the middle, a rather interesting problem that never existed when I was a kid. I didn't know anyone who had anaphylaxis to peanuts, and yet today 3 to or so percent, 2 to 3% of children have peanut anaphylaxis, or at least are thought to have peanut anaphylaxis. In fact, most of those are sensitivities, and very few actually have been tested, who have been tested and demonstrated really anaphylactic tendency that are IgE mediated. Nonetheless, they are treated that way because we see a fixed fatality rate with anaphylaxis. Internationally, 154 fatalities for every million patients who are hospitalized, which is a rather substantial number. In the United States, overall anaphylaxis 1 to 3%, or about 84,000 per year, and 840 of those are fatalities. So this is not an insignificant problem, although it's not that common. And when it occurs, it creates quite a problem for you on a daily basis. In terms of, again, the epidemiology, looking a little more closely at what the actual causes of the allergies are, in terms of food allergies, with 150 fatalities per annum, peanuts do seem to be the most prominent problem. Outside of the operating room, antibiotic allergies, the beta-lactams or penicillin. In terms of allergic vaccines, we see percent and idiopathic. Surprisingly, a whole hodgepodge of causes that really don't add up to any substantial single identifiable feature. But in the perioperative period, unfortunately, this problem appears without much notice, with an incidence of about 1 in 20,000, 1 in 30,000, not much less than the typical mortality associated now with pediatric anesthesia in the perioperative period. But the surprising observation from the epidemiology in the operating room, unlike that out in the general community where those numbers seem to fit your general knowledge base, muscle relaxants are number one, with an incidence of about 1 in 7,000 anaphylactic reactions. How many of you have seen an anaphylactic reaction to a muscle relaxant? 3. Well, that's impressive. 4, I'm sorry. I haven't seen one in 30 years. And were these reactions verified by an immunologist? Yep. Interesting. So we're going to talk a little bit more about why that occurs, because it seems to be quite extraordinarily common in Europe, not in North America. The fatality rate varies depending on the patient's usually coexisting conditions. And as you can see in France, 3% of the anesthesia deaths are due to anaphylaxis. And so Heppner summarized the perioperative causes of anaphylaxis, where 70% of the anaphylactic reactions were due to muscle relaxants, succinylcholine, rocuronium being the most common. And this is overall, this is not pediatric. Latex, 12%, and then there are a host of smaller causes. But so these two, muscle relaxants and latex, comprise about 80% of the causes. But it's still quite unusual, in my experience, in most people's experience, that in North America we see muscle relaxants causing such a high incidence of anaphylaxis. And we specifically in children, we see outside the operating room, food allergies, of course, quite common, although they rarely cause acute anaphylaxis. They are common. Drugs and insects rarely cause anaphylaxis. Antibiotics, we know. And again, the data out of France suggesting that neuromuscular blocking drugs cause more anaphylaxis even than latex. Although in children, latex anaphylaxis in our experience seems to be the most common cause, with atopy and spina bifida multiple surgeries being associated more commonly with latex anaphylaxis. So how is it that the incidence of anaphylaxis to neuromuscular blocking drugs were characterized, and how is it that it's come to such prominence? Well, France has probably the most comprehensive database for reporting anaphylaxis and allergies in any country. And they arrived at, after several reviews, with their incidence of about 60% for neuromuscular blocking drugs, 20% latex, and many fewer antibiotics, with women having 4 to 8 times greater incidence of experiencing neuromuscular blocking drug anaphylaxis than men, which is interesting to keep in mind as we delve a little further into the neuromuscular blocking drug anaphylaxis question. In children, we see in one review about 266 kids here who had anaphylaxis, IgE mediated, and about half, no gender difference as you might expect, and an increasing number of reactions to neuromuscular blocking drugs and antibiotics with age. But in pediatrics, as my experience would suggest, latex is the number one cause. Now that we know about who's at risk, we're not using latex anymore in the operating room, and is much less available outside, that incidence of latex anaphylaxis will wane over time. But neuromuscular blocking drugs still appear to be exceedingly common in kids. And again, we see that number of 1 in 7,700, and Mertus has been responsible for publishing a lot of this data out of France. So if we give more consideration to what is going on with neuromuscular blocking drugs and why people have allergies to an anaphylaxis to succinylcholine and rocuronium, we look specifically at some countries in Europe outside of France. And we see in Norway, the incidence of anaphylaxis to neuromuscular blocking drugs are substantially greater than latex. Whereas in Sweden, there's tenfold less anaphylaxis to neuromuscular blocking drugs than Norway. These two countries are side by each. Why would there be such a discrepancy between two countries? Probably practice similar anesthesia. They almost certainly have drugs manufactured by the same corporations and have such a dramatic difference in the incidence of anaphylaxis to neuromuscular blocking drugs. Well, amongst the... Oh, is it this?
Sorry, guys, if the external sites could just mute their mics. It's sort of coming back here.
Already continue? So the surprising thing, and something that's inconsistent with IgE-mediated anaphylaxis, is that this happened at the first exposure. That these patients who received rocuronium had never received rocuronium, or in some cases an anesthetic before. And on their first exposure, they developed anaphylaxis, which doesn't make sense. If it's an IgE-mediated response, something had to trigger some memory. And so it's suggested, of course, that in rocuronium, that we have quaternary ammonium moieties. These epitopes, they recognize, are present in a lot of other compounds. Specifically in cough medicines, and we don't have those cough medicines in North America, but it's the drug that's most commonly prescribed over the counter there is Folcadine. In toothpaste, detergent, shampoos, and some cosmetic products, which is probably how we see this huge differential in the incidence of anaphylaxis between females and males. And whether it's lipstick or something else that gets on mucosa, the women become sensitized. So it's from the community exposure to some of these compounds with quaternary ammonium moieties that patients or individuals become sensitized, and when they get their first exposure, for example, to rocuronium or succinylcholine, they trigger an anaphylactic reaction. So, what about the difference between Norway and Sweden? Well, Norway has Folcadine. Sweden uses very little Folcadine or doesn't have any available. And remember, there was a far greater incidence of neuromuscular blocking drug-induced anaphylaxis in Norway than there was in Sweden. So Johansson looked at the Folcadine consumption in the two countries, looking at the number of patients who are sensitized to Folcadine in the black bars. And you can see in the countries, about 7 or 8 countries, where there was a huge incidence and consumption of Folcadine-containing compounds, more than 100 kilograms per million people, there was a far greater incidence of sensitization to than in those countries where there was very scant consumption of Folcadine. And the arguments have gone back and forth about whether or not Folcadine was the actual putative agent that has been associated with the anaphylaxis from neuromuscular blocking drugs. And Flurvag recently published their analysis of the suspected anaphylactic reactions over time in neuromuscular blocking drugs and succinylcholine. And what's not shown here is when Folcadine was banned in Norway, which was about 2007. And within a year, starting in 2009, there's been a dramatic decrease in the number of anaphylactic reactions to neuromuscular blocking drugs. So while there may be some academic exceptions and arguments to Folcadine being the sole cause of anaphylaxis in this situation, the removal of Folcadine-containing cough medicines from Norway certainly suggests there's a direct relationship between sensitizing large numbers in the population and administering quaternary ammonium neuromuscular blocking agents and developing anaphylaxis on first exposure. And this is one of the first times that I think we have come across a community-acquired sensitivity to an epitope that ultimately leads to anaphylaxis on the first exposure in the operating room. And we don't have full-containing cough medicines in North America. And why you have 4 individuals here out of about 30 who have seen anaphylaxis to presumably rocuronium is interesting, and it's quite exceptional when I've asked for hands before in audiences on this subject. So let's just give you a little example of a rocuronium anaphylactic reaction that was recently reported. And illustrate a new treatment for anaphylaxis that we don't really have available as yet in Canada or the United States, but that may be coming soon to you. And this is a young female who was undergoing general anesthetic, infertility, and presumably a totally elective case, totally healthy person, propofol, fentanyl, and then rocuronium IV for tracheal intubation. No antibiotics were given, no other drugs. And 30 seconds after the rocuronium, we see coughing and sinus tachycardia. The anesthesiologist declared that the patient could not be ventilated by mask, and so quickly turned to tracheal intubation. After intubation, tube went through the vocal cords, no capnogram. Very high airway pressures. Saturation is now rapidly deteriorating. No carotid pulse, so we have electrical mechanical dissociation, CPR, and the resuscitation began. So you can just see yourself in this picture. IV fluids being pushed in, and IV epinephrine being repeatedly administered without any clear evidence of restoration of circulatory homeostasis. 20 minutes later, they're still doing CPR and trying to resuscitate the patient. Despite their best efforts, peripheral perfusion was poor. The patient looked dusky and mottled. Does not sound like we've turned the corner. Still, no blood pressure and poor saturation. So, they're desperate move. They're looking at vasopressin, glucagon, but instead they reached for Sugamidex. And they administered, 5 or 6 milligrams per kilo. And within 45 seconds, the patient opened their eyes, reached for the endotracheal tube, and extubated herself. And she was completely free of any signs and symptoms of anaphylaxis. Now, complete recovery, discharged, and had no recollection of the event. And you can see that she tested positive for sensitivity to these muscle relaxants. And the question is, why don't we have Sugamidex today? And it's not approved by the FDA, it's not approved by HPB. And the reason is, it was originally developed by a company by the name of Organon, which no longer exists. And why is that important? Well, because Organon brought to market another drug that didn't last too long in the market. It's called rapacuronium. The problem with rapacuronium, of course, was very difficult, isolated incidences, no data reported, no data in the package inserts, but isolated instances where ventilation was not possible after administration of the drug. It was like ventilating a brick wall. For those of you who gave rapacuronium, you know what I mean. And then we reported in anesthesiology about 19 cases, 3 of whom died, and that within 1 month led to the withdrawal of the drug. Sadly enough, Sugamidex, subsequently developed by Organon and sold to another company, who then took it to the FDA, but the FDA know full well that Organon had developed the drug and are quite suspicious that there may be allergic reactions that have not been reported with the database that was submitted to the FDA. So they forced the submitting company to go back and do more studies. And yet here we have an example of Sugamidex reversing an anaphylactic reaction to rocuronium. It's a little ironic in my view that these are the only, I think Canada and the U.S. are the only two countries in which that drug is not available. Sugammadex is not available, and it's because of its tendencies to cause anaphylaxis. But there are now 2 or 3 cases in the literature of adults in Europe who developed anaphylaxis to rocuronium, whose lives were saved by administration of Sugammadex. And just to briefly remind you, Sugammadex is based on a cyclodextrin, which is a conically shaped compound in a cylinder called a toroid, and it's designed to trap specifically, in this case, rocuronium and vecuronium in its inner tube just through van der Waals forces. It's not actually a binding effect, but there's the quaternary ammonium group on the side, and it gets trapped, as you can see. Sugammadex, rocuronium, slips inside, and these two moieties adhere to one another and traps it. So hopefully we'll get Sugammadex. It's apparently extremely expensive, and for those of you who have had reactions to rocuronium, it may make the resuscitation a little easier. So let's turn our attention to another compound that's associated with anaphylaxis and allergies, propofol. Propofol crystals shown here on the left, and the emulsified compound on the right. And propofol allergies are supposed to be extremely rare, in the neighborhood of 1 in 15,000. Of course, there are many reactions, but most of them are not immunologic, and you can see here the immune reactions are about 1 in 45,000. But supposedly the incidence of anaphylaxis to propofol is greater than 1%, with isolated bronchoconstriction, the manifestation. I'm not sure about that. But the patients who've had anaphylactic reactions to propofol have had so also on their first exposure. And exactly why that has occurred, once again, has caused a great deal of consternation on the part of researchers, but presumably isopropyl epitopes in the propofol may, once again, cross-react with products in cosmetics and some medications. But it remains a conundrum why propofol may cause an anaphylactic reaction on first exposure. And then we have multiple exposures associated with allergies to other compounds like soy. So if you just show a list on the top of the slide, the constituents of propofol, you can imagine what people may be allergic to. Number 1, we can see soy, and people may be allergic to soy. Not likely to glycerol, but perhaps to egg lecithin. So in terms of soy allergy, the AstraZeneca website suggests that all the soy proteins are removed during the manufacturing process. And without proteins, we cannot generate anaphylactic reactions. Egg allergy is another potential source of anaphylaxis, and that's due primarily to the protein, the albumin, not to phospholipids. Phospholipids are normal cell-building components that we all have. We only develop anaphylaxis to proteins. So to have egg allergy to a phospholipid, or any phospholipid, doesn't make sense, except if a protein is dragged along with a phospholipid, which is exceedingly unlikely. And in fact, allergies to lecithin, phospholipid, have not been reported. So AstraZeneca have made it clear, as long as you're using AstraZeneca manufactured propofol, are you using Diprivan here mostly? Or are you using generics? Yeah, well, depending on their source, North American made anyways, propofol is supposed to remove all the proteins. Not necessarily the case for foreign propofol. In terms of soy allergy, a number of children are allergic to soy. There's no question about it. Upwards of 0.5%, perhaps even more, and most commonly under 5 years of age. It's primarily a gastrointestinal problem. It doesn't cause anaphylaxis. And so in terms of your anesthetic, a child comes in with soy allergy, giving an IV drug that contains soy is unlikely to cause an immune or anaphylactic reaction. We have generally considered soy allergy to disappear by the age of 5 years, and it looks like it's not exactly the case. You can see here the persistence of soy allergy with age, and we would have thought that almost all the kids dropped off to zero by 5 years of age. It actually lingers. And if you look at why these Kaplan-Meier curves continue and break it down onto their sensitivity to soy, those kids who have extremely high sensitivity to soy persist to almost adolescence, whereas those who have much lower sensitivities do drop off by 6 or 7 years of age. And the reason they drop off is that 95% of the foods you ingest contain some soy. And so it's not possible for your bowels to not develop a resistance and reduce its sensitivity to soy. So it basically disappears on its own. But why are so many children, even 0.5%, sensitive to soy, which, again, was not the case when I was younger? And this quotation from the internet suggests that we've done it to ourselves. In order to improve the production of soy crops, we've sprayed them. And some of the epitopes in the antifungal agents that have been sprayed to improve the quality of the crops contain epitopes that are shared by other compounds that lead to sensitivity and allergies. So this is a problem. And it's shared in this example here with peanuts. We're in the investigation. And so we can see now that there are not naturally occurring sensitivities to peanuts, but actually compounds that are sprayed on the peanuts, absorbed through the shell, get into the peanut, as well as into the soybean, that ultimately is made into a number of foods. And that may be exactly why we have an escalating incidence of allergies in kids, whether it's peanuts, soy, or otherwise. And what about egg allergy? And the package insert for propofol suggests you shouldn't give propofol to patients who have egg allergy. Has anyone ever interviewed a patient who had anaphylaxis to egg? I don't think so. It's extraordinarily rare. But as we mentioned earlier, allergy and egg allergy are due to the albumin or the protein, which is primarily in the egg white, not the egg yolk. And there are only 9 proteins in egg yolk, and only 2 of them particularly are allergic. Phospholipids, as I said, is a non-protein. And lecithin should not cause allergic reactions. So the probability of ever having an allergic reaction to egg by giving propofol is extremely small. And this chap, Murphy, who's a medical student, lead author on a paper in Anesthesia and Analgesia last year in Australia, they reported their experience with a bunch of children who have had egg allergy, who received propofol on 43 exposures. And you can see that none of them had allergic reactions, although it was a non-immunologic anaphylactoid reaction in one child. And the conclusion is, if the child or person has anaphylaxis to egg, it's probably wise to avoid propofol, which will mean you can give propofol to virtually anybody who says they have egg allergy. But it's probably good to check what the allergy is. And unless they have a medical alert bracelet, they've been tested for anaphylaxis, it's almost certainly just a sensitivity. It's not anaphylaxis. Having said that you can't be allergic to a phospholipid, it was interesting in Rochester to look at the electronic medical record and review the allergies. And one of the residents called me and said, you got to take a picture of this because here's egg lecithin listed as an allergy. It's like being allergic to epinephrine. This is a naturally occurring compound in all of the cells in your body, and the phospholipid cannot itself cause allergies. But as happens in most hospitals, if the parent or patient comes in and says, I'm allergic, because they think they are, or they believe they are, or someone told them they are, it gets transcribed, and it will never be removed from the chart, no matter how hard you try. So the only way to protect yourself and to give the patient optimal care is to go through allergies that are listed on the chart or reported by the patient and identify exactly what the allergic reaction was. and a rash, these GI symptoms, vomiting, not the same, not a concern to us, not like those associated with anaphylaxis. And then there's the peanut allergy. Again, very common, 1.5% of children. Only now that we can immunologically test for the arachidonic acid components, the ERA H1 to 3, 80% of the children who report peanut allergy are sensitive to peanuts. Only 20% have true anaphylaxis. And there's no point in telling the parents if they had a reaction, then they probably were advised not to have peanut-containing compounds, but the majority are sensitive. The incidence is stabilized out at about 1.5%, and hopefully we'll get some of the bad things that are sprayed on the crops removed, and this incidence will die away with time. And there is a cross-reactivity with soy allergy, so don't be surprised if they suggest that they're allergic to both. And in terms of children, you can see that the percent of children who are allergic to foods as they get older decreases. This is allergy-free children on the y-axis. So there's allergy-free. As a young age, they will be sensitive to eggs and milk, but as they get to teenagers, that virtually disappears. They grow out of much of the allergies. Peanuts, though, allergy stays with you for life. If you have anaphylaxis to peanuts, that doesn't go away with life, or with aging. So you have to be careful of that. So we all are familiar with latex allergy. It's brought, as I started off the lecture, brought anaphylaxis to the forefront in the perioperative period, and primarily to do with the AIDS epidemic. And why is that? Because there was such a demand for latex products that instead of sitting on the wharf and cross-linking after it was vulcanized and treated, a lot of the latex products were quickly shipped off and manufactured into gloves, condoms, and these products were incompletely cross-linked and allowed shedding of somewhere in the neighborhood of 100 or 150 protein moieties when they're rubbed. These became absorbed through the mucosa, and patients became sensitized to latex. Foley catheters is what brought it to the attention of pediatric cases because many of the children with spina bifida and chronic urologic problems required hourly or every 4-hour catheterizations. And so, as I said, by 1994, there were 16 deaths alone due to latex. So there are basically 3 forms of latex allergy we need to be sensitive to. Number 1 is a contact dermatitis that occurs, that it's an inflammatory response from wearing gloves. It does not connote a systemic response. The skin will be dry and cracked, and if you test for latex allergy, they don't have the systemic manifestations. There's allergic contact dermatitis, which is a type 4 hypersensitivity. Again, not IgE mediated, not going to cause latex anaphylaxis. And then there's the type 1. Often severe reaction, swelling of the lips, the tongue, difficulty breathing, tight chest, all the typical manifestations that you would expect associated with an IgE-mediated anaphylactic reaction. And as the surgeon dips the latex gloves into the patient's peritoneal cavity or in the chest, many little latex particles are absorbed into the circulation, and the patient suddenly becomes difficult to ventilate and hemodynamically unstable. In children, as I mentioned, the cohort are very clear: spina bifida and bladder problems, more than 4 surgeries. And my acid test to these children, or the parents, is that if they have a sensitivity to toy balloons, when they hold the balloon to their lips, or if a balloon bursts and they suddenly notice they have shortness of breath, as my wife gets, as she's developed a latex allergy, and she bought a number of balloons, had them inflated to take to our daughter's house, and one of them burst in the car. It was summertime, it was hot in the car, and she suddenly realized that she got tightness in her chest. So it can be quite disconcerting. And there is, of course, a cross-reactivity because of epitopes in a number of fruits and vegetables. And actually, this list, of course, is totally incomplete, but you can virtually name every fruit and vegetable that has been associated with a cross-sensitivity to latex. So how do we reduce latex allergy? Well, we have eliminated latex products in the hospital. We've avoided them. but I can tell you that latex still exists in the community. It's a cheap way of delivering plastic products. And so we have been obsessive, but the patients may still come in with latex sensitivity. Hopefully we won't trigger it in the operating room. But by avoiding latex, a number of studies have shown huge reductions in the incidence of reactions in all the patients, and including healthcare workers. But hospital exposure, as I said, is not the only source, and we have to be careful of it. Sensitivity to latex, markedly diminished by avoiding latex. Now let's just change our pace for a few moments and just try and explore some of the problems associated with antibiotic allergy. Up to 10% of patients have had a history of allergy of some sort to an antibiotic. And most of the pediatric immunologists and infectious disease experts will tell you that if they've avoided the drug for 5 years, their T cells as children lose their memory of the antibiotic sensitivity. Having said that, I always see adults who have told me that they have allergies to penicillin and ask them when they last had it, and they said, oh, they can't remember, but they were a kid. So that really suggests that it's time for them to get re-exposed. Most of those reactions are due to the coloring, the constituents in the antibiotic, not the antibiotic. If I have a choice between testing a patient for penicillin or Ancef allergy versus giving vancomycin, I'll tell them I'm much happier to resuscitate you from an anaphylactic reaction to the penicillin than I am to give vancomycin. There's way more concern I have about giving vancomycin. So most of the children who have developed these allergies have a rash. The rash is probably associated with a bacterial or viral infection. Urticaria is more of a concern. It's very unusual to get anything but a maculopapular rash. So as I said, I give a trivial dose and test IV, and I can tell you that I'm almost certainly much more comfortable giving a little bit of penicillin or Ancef and treating an anaphylactic reaction than any allergist in his office, because most of them haven't treated anaphylaxis. They don't set up IVs before they inject small doses in patients, and they prefer to ship anybody away who may have an anaphylactic reaction than have them have a reaction in their office. But everything has caused an allergy, every one of the antibiotics, including cephalosporins. First generation may cross-react penicillins, but all the subsequent generations of cephalosporins, zero cross-reactivity with penicillins. So you don't have to worry about that. Many of the other antibiotics we don't give IV, shown here, sulfonamides, macrolides, are available orally. Our primary concerns are the beta-lactams. And we have seen, I have in Rochester had a situation where a patient received their first dose of cephalosporin on the floor IV and had an anaphylactic reaction and arrested. So it can be a nasty reaction when it occurs, even with first exposure, and it's not clear why that happened. But the differential diagnosis in general for anaphylaxis, when we finish with our list of the multiple causes, usually we can narrow down the cause from what we've given in the last few minutes. The question, though, is it an anaphylactic reaction? And here we see a number of possible differentials in the diagnosis. And I have to laugh because when I saw they listed panic attack, actually, when my wife had an ultrasound and they asked if she was allergic to latex, and at that time she didn't know she was allergic to latex. So they used a latex cover on the probe. They did the ultrasound, and by the time she left the office, she went outside to get in her car. She noticed she had tingling in her fingers, and her lips felt heavy, and she started to get a little short of breath. Well, our general practitioner is just 3 blocks down the road, so she got in the car and drove over to his place, and by that point she was sweating and flushed and walked in, and the secretary saw her and said, you better get in that room right there. And our GP was a little busy, so he sent in one of his colleagues, and And then our GP walked in, and he said to his colleague, "So what do you think Mrs. Lerman's got?" And he said, "Oh, I think she's having a panic attack. No question." And he said, "She's a nurse. She wouldn't be here if she's having a panic attack." And so they treated her with epinephrine. But it's kind of unusual to see panic attack in Munchausen as a differential diagnosis for anaphylaxis. I don't know how you can fake swelling and all the cardiovascular and respiratory complications associated with anaphylaxis, but clearly it can happen. So Ring has listed a clinical severity score for anaphylaxis, primarily applicable. It's applicable in general, but from our points of view, we don't see anybody who isn't class 3 and class 4 anaphylaxis, because the first two classes are too trivial and would never come to our attention. We probably wouldn't see them. And this is where we need to march in with standard management for anaphylaxis and resuscitation, which we all know, including epinephrine, more epinephrine, and lots more epinephrine. When we had our latex cases, we thought these patients were having some kind of reaction to antibiotics. Nobody had reported latex anaphylaxis before. And we tried every vasopressor in these children, and nothing worked but epinephrine. So I can tell you there's no point in monkeying around with anything but epinephrine and perhaps some isoprel. Secondary agents don't really add much. There's no proof that diphenhydramine, H1, H2 blockers in general, steroids really do much. They're not evidence-based, but for lack of any other drugs to give, they're certainly included, as are aminophylline and beta agonists. But there are instances where epinephrine does not resuscitate these patients. And this is particularly the case in adults who are beta blocked. And it does not seem to be very effective. And in those cases, we need to consider vasopressin and glucagon. And I'm sure you have vasopressin in the operating room. But they have a key role in patients, particularly who are beta blocked, who develop an anaphylactic reaction. And after the reaction, perhaps one of the most important things to do is to draw a serum tryptase right away to get a baseline, because it will go up over time. And then subsequently we'll follow them up with another blood sample at 24 hours looking for a peak effect. And then there's the follow-up with the immunologist, a variety of tests for all these different compounds to which they may be allergic. And that goes beyond the operating room, of course. Our patients get stabilized and go off to ICU if they're the least bit unstable for observation until they can go to the step-down unit. So what do we know based on today's information in the North American literature? We don't see much anaphylaxis to neuromuscular blocking drugs. It's extremely rare. But there's no reason to say that somebody hasn't introduced some over-the-counter medication that's going to sensitize your patients in the future. So we always have to be circumspect to the possibility that our practices are going to change and the incidence of anaphylaxis to drugs that we commonly use will change. Is propofol allergy a common problem? Virtually no contraindications to propofol. And it doesn't matter if the children are allergic or patients are allergic to egg. Unless they have egg anaphylaxis, it's not an issue. I would suspect that within the next 10 years, latex allergy and anaphylaxis will be of historical interest. We don't have latex in most operating rooms. Patients are no longer being sensitized by repeated exposures to latex. That will disappear. And in terms of antibiotic sensitivities, once we're beyond the first generation of cephalosporins, we will not see much in the way of antibiotic anaphylaxis in the operating room. But I still practice as if every drug can cause anaphylaxis. And apart from rapid sequence induction, where I have a reason to give drugs quickly, I don't give any drugs quickly. I don't really give any boluses of drugs. No matter how small the volume, I'll dilute it up to a few cc's and give it over a few minutes. And that will reduce the probability of having a serious reaction, whether it's mast cell degranulation or anything in the operating room. So how do we stay out of trouble? Intraoperatively, patients who have egg allergy, I use propofol because I don't think it'll get you into trouble. Patients who have soy allergy, I still use propofol. That's not going to get you into trouble. Children who have egg anaphylaxis or adults who have been immunologically tested, those are the only patients in whom we avoid propofol. And of course, we use alternate plastics to latex for our gloves in the operating room. And in all instances, we all should have emergency preloaded syringes of epinephrine available. And so I hope that will help you characterize anaphylaxis in your practices, in the operating room, in the community, and give you some hints why we see anaphylaxis with certain compounds, why we don't see it as much neuromuscular blocking drugs in North America, and some insights into latest interventions to reverse anaphylaxis. Thank you very much.
I have a question, Jerry.
Sure.
Do you have any experience, or do you know anything in the literature of the use of vasopressin in children in resistant anaphylaxis?
No.
Guys, if you just repeat the question.
Yeah, I'll repeat it in the mic. What's my experience with vasopressin in children? None. I haven't used it in children. I have in adults. It is impressive. The issue regarding the role of vasopressin for anaphylaxis in children really doesn't come up because we don't often see children coming at all beta blocked. So the role in anaphylaxis really hasn't been seen as prominent. We did try in the course of resuscitation from anaphylaxis every vasopressor, not vasopressin, in the 20 years ago, and nothing really worked. And there was a question over here. Oh, yeah, over there. Yes.
So you said the allergic epitope in neuromuscular blockers is the quaternary aim. So why not a reaction with acetylcholine?
Well, that's a good question, and I don't know the answer. I don't think if it's a quaternary ammonium compounds, epitopes in these muscle relaxants that are triggering the allergic reactions, the question is, what about other compounds that are naturally occurring that have quaternary ammonium compounds? And why don't we get allergic reactions to them? I don't really know. In one of the slides, the histograms, they had a quaternary ammonium marker for epitopes that had quaternary ammonium in them, and they didn't often trigger sensitivities. They weren't measured and picked up like the rocuronium and the folcadine sensitivities. So I don't know what's different about them. Maybe it's a conformational structure. I don't know. But that's a good question, and I don't think we know enough about it.
Jerry, what's the youngest patient you ever had with anaphylactic reaction? Can a baby?
Well, it's pretty unlikely. First of all, under a year of age, 6 months, they don't really have a sophisticated immunologic system. You know, we can transplant hearts and have ABO incompatibility. They don't develop immune reactions. So they probably don't mount much of a response. It's with time. I would have to say that we probably didn't see it in kids under than 4 or 5 years of age. In the days of spina bifida and latex exposure, the youngest age group were the ones who were repeatedly treated with latex catheters. And I must say that it was probably more dependent on when they came for subsequent surgery. For example, myelomeningocele, we'd often operate on them at neonates. It's not a congenital problem, as some parents have been misinformed in spina bifida clinics. They're told, this is a genetic problem. This is an acquired problem, not genetic. They're not born with sensitivity. They acquire it over time. So myelomeningocele, as they get born today, are catheterized with non-latex Foley catheters, so that's the end of that problem. But I would have to say that we generally were performing reparative urologic surgeries in the younger kids, probably in the 4 to 5 age range. That doesn't mean it can't happen in younger. And then there were a host of children who were having scoliosis repaired, who of course were teenagers. And some of those were hairy because we had one lung anesthesia going on and they had an anaphylactic reaction, which was quite disconcerting. But that's a good question. I have to look back at the original publications to see, or look in the literature to see what's the youngest age at which latex anaphylaxis has been reported. I don't know off the top of my head.
Does anyone from the other sites on the island have any questions for Dr. Lerman on the island, or? Guess not.
No. Yes.
I went to a talk at an ASA a few years ago, and it was a Danish group who were allergists, and they spoke about their experience with chlorhexidine. And they felt that, at least in Denmark, that was a significant, it was a common cause of anaphylaxis in the operating room, and the timeline was often delayed from exposure. So the patient's abdomen would be prepped, and then the incision was made, and it could be 30 or 45 minutes later that the chlorhexidine was absorbed and creating a reaction. I've spoken to our local allergist, and he doesn't seem to know much about that. I wonder if that's something that we don't think enough about, and patients who didn't get antibiotics or didn't have a reaction to rocuronium, maybe we should think about chlorhexidine.
I know people have repeatedly, healthcare workers gotten chlorhexidine on their hands, have started to develop a dermatitis to it. I'm not sure about the absorption of chlorhexidine through the skin. I don't know how widely. It's interesting. The question was, what about allergic reactions to chlorhexidine? And I don't know that anything about the absorption, but God gave us a stratum corneum, to block toxic compounds from the outside getting in. And without a skin incision or mucosa, not being applied to mucosa, it's kind of curious that you could absorb enough of this stuff on your skin that, but it's dried on the skin and presumably can't get in once you've begun the surgery. So I don't know the answer. There's perhaps many questions about chlorhexidine, but it's not an area that we've actually focused on in the operating room at all.
I'm thinking about a very genuine appearing anaphylactic reaction in a patient I looked after a couple of years ago that the allergist threw his hands up in the air and said,
I'm sorry.
Right. So they retro-engineered it, made it Agent Orange resistant.
talking about Monsanto, I think.
So that you had a reaction and they couldn't find the
Yes.
putative
And
agent?
the frustration of never knowing what caused this reaction, and the concern that this individual will come back for another anesthetic one day. I'd still.
Do you think the question of failure to make the diagnosis, that's a problem with allergic testing. That's a big problem. And whether they have a sensitive test for chlorhexidine reactivity, that's another problem. So I don't know the answer to that, but I know there are reported cases in the literature of chlorhexidine sensitivity, and that was a problem when it was introduced. I don't know much more.
Hey, there's a question. Did Jubilee have a question there? You guys have a question over in Victoria?
Yeah, can you hear us?
Sure can.
Yeah, Jerry, I don't know my generations of cephalosporins, but if you had somebody who says they're penicillin allergic, can I give them Ansef? Cephalosporin?
Well, and do the other centers hear the question?
If you guys turn off your mic, we'll... Can you guys turn off your mic after you've said the question there?
So the question was, what about Ansef after penicillin allergy? And Ansef, cephalosporin is a first generation. So I'd be careful, and I would probably explain to them that the probability of having a cross-reactivity is extremely small. The alternative antibiotics may be rather toxic. And as long as you're comfortable, I would dilute up the antibiotic and give 5 or 10% of the full dose and monitor the patient for a few minutes, IV. And if there's no reaction, then I would continue to administer the drug in incremental amounts. And then make sure you tell the patient afterwards, that they do not have allergic reactions. I've done this innumerable times, especially to avoid in children undergoing cardiopulmonary bypass, because the alternative the surgeons wanted was vancomycin. And at least in the children I've given it to, I've not seen or documented any cases of anaphylaxis. It's exceedingly rare. The 10% data, by the way, in the cross-reactivity between penicillins and even first-generation cephalosporins is extremely poor. It's retrospective data. It's extremely weak. And there has been no follow-up to repeat that kind of cross-reactivity. So I would not really, I don't hold that data in high regard. So I do give Ansef to patients who are allergic to penicillin.
All right, so a couple of little housekeeping things. I wanted to thank, first of all, ASCO. I forgot to do this the last couple. Abbott sponsors this visiting professor with an unrestricted educational grant, so we can bring all-stars like Dr. Lerman here. So thanks, Dan, very much. There's some sign-in sheets came a bit late, so on your way out you can sign in. There's also the evaluations, which would be great if you fill out. And finally, we have the coveted visiting professor certificate that Dr. Lerman he can put up on his wall.
Thank you very much.
Sorry guys to bother you. Vernon here. Can I talk to someone from audiovisual, please?
Oh yeah, well, you know what? They obviously have issues, and
Did you have, you're not in Toronto anymore?
no.
Did you have any, do you have any decent allergy people in Toronto?
Well, we,
And this is my huge frustration.
I'm just, unless somebody gives a very strong history of penicillin allergy, I have no problem giving consent. The problem is,
And he gets Ansef, and he gets propofol, and he gets some fentanyl, he gets some rock, and he gets a tube, and like 15 minutes later, he has no blood pressure. He is red all over. I can't ventilate. This is just like, this is, oh my God. So he gets everything, and he gets glucagon, and he gets vasopressin, and we got him back, and he's staying in the hospital. He had a recrudescence. And they treated him in the ICU again with Epi in the night. Still, and so the allergist, you know, I mean,
there's no
Tom,
money in the academic.
it's
They're
not. It's
giving
hopeless.
needles.
So does he want? He gives the guy a Lancet one day, and then he says, like, one of our anesthesists, Peter McGinn, has a great interest in allergy, and Peter has often worked with the allergist. Like, he'll go once every 6 months, and they'll have a clinic together. So if somebody does arrest, Peter's there to do the right thing, you know. So it's just hugely frustrating.
Milt Gold was the original immunologist on our latex cases. He put the whole picture together, and that was how they got out.